Start with the endocrine. All right. So here we see a pancreatic cell, and we're going to talk about different cells of the islets of the Langerhans and what they produce. Right. So here we see the pancreas, which is drawn out here, and what they did is basically in this box they basically magnified this out, and we see the following cells. The ones we are definitely need to know for these exam is the ones that I'm going to highlight here. So we have the beta cells of the islands of the Langerhans, and they produce insulin. And then we have the alpha cells, which produces glucagon. We give this medication, right, of glucagon medication that we can administer to the patients who have hypoglycemia. And in a setting we are unable to yet gain IV access, right? Or we tried and it was difficult access, but the patient has low sugar, right? We check them on our glucometer. And so we're giving glucagon. This is the medication you have to reconstitute, right? It comes in the powder, right? You reconstitute, you mix it, and then you draw it up. Do not drop the powder medication. You have to reconstitute it. The other reason we use this medicine, right, for beta blocker overdose, and the dose is 50 micrograms per kilogram, right? That was the initial dose for beta blocker. And some of you may not have this amount in your ambulance. You're definitely going to have to call medical control as a discretionary order, right? And so what is the insulin, right, and glucagon? So they work in opposition to each other. So an easy way to remember this, right? When does the body release glucagon? When the glucose is gone, right? So if you have glucose that's gone, so you're in low state of glucose, so it's hypoglycemia. You have a release of glucagon. So again, when is glucagon released? When the glucose is gone. What cells make it? The alpha cells of the islands of the Langerhans, and this is the endocrine function. What is endocrine, right? So endocrine means it goes into the blood, right? It travels into the bloodstream, right? And you see these capillaries, how they go, right, in the network around all these cells. And once these hormones are secreted, they will be uptaken into these capillaries, and they're going to become systemic, right? Pancreas also has exocrine function. So unlike endocrine, this is your digestive enzymes, right? The pancreas produces, which is secreted into the small intestine, right? You have different lipases, amylases, proteases that are being secreted. Why do we need that? To chop up, complex molecules, right? Your proteins, your polysaccharides, right? Your sugars, your glycogen, right? And it helps with emulsification, right, of fats. So this is the role of the pancreas, right, that we see here. So let me show you again, right? So this is what we have. Somatostatin is basically it's a hormone that basically functions in an inhibitory function. Not going to be on the exam, right? So you do not have to remember that one. But delta cells produce it, right? So it has the inhibitory function. So this is just a close-up view, show you the beta cells, right, that are highlighted here, right? And they're basically the products of that, right, will be uptaken by the capillaries. Here we see the alpha cells. So beta cells, insulin, and alpha cells, glucagon. And when does glucagon released? When the glucose is gone. So if you have a question that's saying, right, you have, a person who has, this condition, these vital signs, and his sugar level is this, right? What is the hormone that's going to be released, right, to counteract that, right? So low sugar, think glucagon, right? If you just ate post-meal, you have high sugar, that's when insulin is being released. Here, right, we see both the endocrine and exocrine functions, right? So what's the endocrine? I would just explain to you, right? It goes into secretes the digestive enzymes. that we see here. And we see it right from the pancreatic duct. The digestive enzymes will be secreted and into the small intestine, where the digestion and the chopping up of macromolecules will occur to basically get them into single molecules or monomolecules, like monosaccharides, like glucose, right? Amino acids, fatty acids. And so we're going to chop this up in order to break this down so we can utilize it, right? Well, why is glucose important to us? We use glucose as the substrate, right, for the body, especially in the mitochondria, to make ATP, right? So if we have in our body, we have oxygen, we have glucose, we're going to be making roughly 38 ATP, right? There was a slide. I'm going to go up higher just to show you the numbers of this pathway. I did go over it in the other videos, but just since it's relevant, I think it's important to show you here. Right, so per mole of glucose under aerobic conditions, we make roughly 38 ATP, right? And when we have anaerobic conditions, so right, lack of oxygen, per glucose, you only make 2 because your body's only using glycolysis to do that. What's the importance of this? Remember, I was showing you sodium, potassium, ATPases, right? We had these channel pumps, right? Sodium, potassium, ATPase. Body uses about 25% of ATP just to drive these pumps, right? To restore the action potential, right? Back to negative state. It uses ATP, so it uses energy to drive, right, ions against their concentration gradient, right? If you recall, right, I remember I was telling you cells are usually bags of what? Cells are bags of potassium, right, in a sea of sodium. And when we have depolarization occurring, sodium rushes into the cell, right? And then we have hyperpolarization by potassium, so potassium is leaving. We need some sort of a pump to restore that gradient back to the resting state, right? So we have these sodium potassium ATPases. They're embedded on the cell membrane. There's a lot of them, so it's just, let me draw a couple, right? So they're on the cell membrane, and their job is to pump sodium and potassium ions. So we call them sodium potassium ATPases. It's 3 sodium for every 2 potassium. So the question now becomes, right, what does it do? Does it pump sodium inside the cell, or does it pump potassium inside the cell? So who can answer me that question?
Sodium outside of the
sodium
cell.
in.
Sodium outside the cell?
It pumps the sodium outside the cell? And then what about potassium?
Inside the cell.
Okay. Very good. So you see how it does so, even though the concentration gradient, right, is higher, so meaning it does so against the concentration gradient. That means that when it's pumping sodium outside, it's using ATP to do so. And when it's bringing that potassium in, right, it's again utilizing the same ATP to do so. This is called active transport, unlike passive transport, right? And active transport, we utilize energy molecule, here being ATP, right? So this is the energy molecule, adenosine triphosphate. And we use this energy molecule in order to pump ions against their concentration gradients. Why do we need to do this? We need to establish that negative, let's say 90 millivolts resting status of the cell. And to do so, right, we need some sort of a pump that will do that. Because throughout the depolarization and repolarization, we had what was happening, right? We had sodium channels that were voltage gated that allowed a lot of sodium to trickle inside the cell, and potassium was leaving. So we have to find a way to basically get these ions back, right, to their respective compartments so that this process can occur, right? And it's driven by this, right, sodium potassium ATPases. They utilize about 25% of ATP that our body makes, right? And it's not just, in these cells. Remember, I was showing you in the kidneys. Kidneys on the basolateral side have the same sodium potassium ATPases that are functional, right? So it's important for the ATP right, to be utilized. And in the setting of shock, right, or in the setting of acidosis, where you have lack of oxygen, you could obviously understand, right, we may be lacking aerobic respiration, so not as much ATP is being produced. So a lot of these processes may be, right, slowed or not working, right? So we want to restore, right, the oxygen status. We want to restore the body's demands, right? And how do we do that, right? So we resuscitate them. Maybe we need to get their blood pressure up. Maybe we need to give them oxygen support, right? So depending on what the patient needs, that's what we're providing them. So this is just on that. Any questions about the sodium potassium ATPase, right? What's the difference between this versus passive transport? So active transport usually against the concentration gradient utilizes energy. Passive transport is usually does not utilize energy molecule like ATP, GTP, and it's usually driven, right? Could be a concentration gradient like diffusion, right? Any questions about this?
This is happening during the revolarization step. That's
Yeah. So they're basically constantly, right, working to pump out, right, sodium out and potassium in consistently, right, so that the cell is maintaining, right, the resting status, right. So this is actually working throughout. Same thing in the kidneys, right? This is occurring throughout. All right, so let me go back to the other slide I was showing. Something else, since we're already on the topic, and I'm going to ask you guys, since you already talked about the lecture, I saw there was an article posted by Matt, right, in the setting of sepsis, right? Why do you have hyperglycemia? Were you guys asking that question in the lecture?
What was the question?
The question was, I saw it was an article Matt posted on Google Groups. Says that there were somebody asking, why is there hyperglycemia in sepsis?
Yes, that was a question from somebody. Yes, I saw the email.
Yes. Does anyone know why there is hyperglycemia in sepsis?
Maybe because the body is in distress,
Okay, and how does that produce hyperglycemia?
to respond to the need, because when the body's in sepsis, it's an overdrive. And in order to make sure we fuel that overdriven mechanism, for lack of a better word, we need to go ahead and supply this energy.
Okay, and how does
Am I pretty
the
much
body do
on
it?
the right track?
And how does the body do that?
Carefully.
But I'm looking
glycogenesis.
for, since this is, right, AMP lecture, I'm looking for specific reasons, right?
through glycogenesis.
Glycogenesis, so not necessarily glycogenesis. So the words may sound similar, but it's not glycogenesis. Glycogenesis is formation of glucose, right? So in the
glycogenolysis.
Glycolysis.
yeah. So Adam is correct, right? So that's one of the processes. So Irene, to kind of like give you the AMP perspective of it, right? So what you're saying is not incorrect. What you're saying is the body's in stress, right? And then when the body's in stress, it releases what's known as counter-regulatory hormones. Right? And what they are is this, right? So it's epinephrine, it's cortisol, it's growth hormone, and it's glucagon, right? So when your body is in stress, it's going to release these counter-regulatory hormones. And, right, we just talked about, specifically, we talked about glucagon. So when this glucagon released, when the glucose is gone, so this will mobilize, right, glycogen stores. And also epinephrine is released, right, and cortisol. And what a lot of these hormones do is they start to activate these two important processes. So one process is called gluconeogenesis, Let me use a different color. And the other process is called glucogenolysis. So the difference is this. Well, before I tell you the difference, who could tell me the difference between these two processes?
PO is new, so it's making new.
Okay,
And
so
like
what are the new sources?
the new sources is from fats and carbohydrates. And not
Well,
carbohydrates.
not carbohydrates, but
Proteins.
right, probably amino acids, right?
Amino acids almost.
Glucogenic amino acids. So what gluconeogenesis, the stress is on the neo. So it's the actual definition being formation of glucose from non-carbohydrate sources.
So is it getting the protein from like muscle breakdown?
Yeah, it could be
Fat and
muscle
protein,
breakdown, right? Exactly, right? So if it's long enough, absolutely, right? Your body's basically gonna eat up itself. So it's gluconeogenesis, and then the other process called glucogenolysis, and this is basically breakup of your glycogen stores. And usually in our body we have roughly about 24 hours of these stores. So after like a day or two, right, you probably exhausted all your glycogen stores. How does the body release the glycogen stores, right? We have the glucagon that's going to basically act on the liver, and we're going to mobilize these glycogen stores, right, to release into the bloodstream. Things like epinephrine, right, is going to stimulate gluconeogenesis to start working. And we see also, right, glucagon also contributes to that. So this is these are the two processes that we see are working in sepsis, right? So sepsis in a sepsis-like state, when your body's in shock, it wants to have more glucose. Your organs also, right, are underperfused, so cells underperfused. So it's another way, another reason for the body to try to mobilize, to push the sugar towards these underperfused cells. So basically, it's a release of these counter-regulatory hormones. These processes of gluconeogenesis and glucogenolysis, and also the underperfused cells that the body's trying to perfuse and get the sugar to them, right? We also see, right, the spike. So the person may not have like diabetes per se, but we check their sugar, right, and they may be like 200 milligrams per deciliter, in a sepsis-like state. So this is the cause of this, right? And then I think Helmi was using the word glucogenesis, right? What's this?
Combining glucose to make glycogen.
What'd you say, Brian? I think you were correct.
Combining glucose to make glycogen. For
Excellent,
storage.
right? Excellent, right? So usually this is right. When we have high insulin release, and you basically, let's say you eat a lot of pasta, you eat a lot of carbs, right? And your body's saying, right, a lot of sugar, a lot of carbohydrates are coming inside my body, right? I don't need this right now. I could store some of this, right? So it's starting to form, right, glycogen stores, right? Or it gets deposits into fat, right? If you overeat, for bodies using it on a rainy day, right? Such as sepsis, for example, or starvation, or anything like that. Hopefully that's clear. You guys have any questions about that?
And so a septic patient would probably be less likely to be eating as well. So that might.
Lindsay, what'd you saying?
That a septic patient would be less likely to be eating normally as well. So would that be encouraging the gluconeogenesis?
So it can or may not, but usually it's basically a body's response to the shock status, right? And it's doing so, right, basically twofold, right? These counter-regulatory hormones are released, and the underperfused body is trying to basically push glucose into the cells. Why? Because you need glucose as a substrate, right? So glucose, in a sense, glucose is a substrate. It's a monomolecule, and we need that, for, glycolysis and for your citric acid cycle and then basically electron transport chain. And the whole goal of this is to make these 38 ATP, right? So that's why we need to get this into the circulation so that we can utilize, right? But there's also, right, another danger of this as well, right? If certain bacteria, right, they drive their metabolic glycolysis via glucose, right? So you're also giving some sources of substrates to the bacteria as well. But the predominant response for the body is basically just the counter-regulatory hormones that are being released because the body's trying to survive. That's the main inherent reason why you see that elevated sugar level.
But those hormones, aren't they like they make your sensitivity to insulin go down, so that also keeps driving it up? Like even if you were going to give the person insulin, it wouldn't really bring it down. There would be some resistance.
No, I will bring it down because, like I said, the septic patient may not have diabetes, and these are released in the status, right, of shock. So unless you have, consistently, right, where you have the release and you have receptors that are down regulated, right, or not as functional. When a person who doesn't have diabetes, you give insulin, definitely going to drive it, right? You're definitely going to drive, By the way, which glucose transporters are insulin dependent?
Beta cells.
What, 3, I think?
Four.
Four.
Oh.
So not the beta cells. Beta cells make insulin, right? But glucose type 4 transporters is the transporters that are found specifically on adipose, right? And fat cells. So let's say this is fat cell, this is muscle cell. And we see, right, when insulin binds to a receptor, it triggers the machinery of these glucose type 4 transporters to basically express on cell surface. So then we see these glucose type 4 transporters start to appear on the membrane surface, and they can then drive glucose into the cell. So glucose type 4 transporters are the transporters found on cell surface after insulin, right, binds on the receptor. Just a note on that, right? The central nervous system is not it's not insulin dependent for glucose utilization, right? So your CNS, right, and red blood cells, they don't need insulin to bind there to drive glucose. Your adipose tissue, fat cells, muscle tissue really needs insulin in order to uptake, sugar. All right, so this was something about the pancreas, right, about different hormones and secretes. So this, we kind of explained this a little bit, but hopefully this makes even more sense. Depending on the textbook you read, so this book utilizes 70 to 100 milligrams per deciliter as the normal glucose level for, let's say, an adult person. Below 70 will be hypoglycemia. Above 110 will be hyperglycemia, elevated sugar. So now we got to basically see what the body does to reach homeostasis. So let's first talk about, right, when you have ate a lot of food. Let's say you ate a lot of pasta, right, or ate a lot of carbohydrates, a lot of sugar. So the body is sensing the rise in blood glucose levels, right? So your blood has a lot of sugar in it. So the body's response to that is for the pancreas to start releasing insulin. How does it do it, right? The beta cells of the islets of the Langerhans, right, they're going to secrete insulin. Which cells are going to do it? It's the beta cells. And, right, once insulin is released, the capillaries in the pancreas will basically uptake this insulin and they will send it into the bloodstream, right? So what's the effect? Right, so it increases glucose transport to the target cell. Specifically, it's going to do so with glucose type 4 transporters, which are found predominantly in your adipose and your muscle cells. Right, and why do we need that, right? Increased rate of glucose. So as I said, glucose is your substrate that's needed for ATP generation. Where does it go, right? In the mitochondria, right? Once it's broken down in the processes of glycolysis, then electron transport chain, and then, glycolysis, then citric acid cycle, and then electron transport chain, the net result, right? If we have oxygen, we're going to make 38 ATP. And as I just showed you, right, we need ATP for these sodium potassium ATPase is just an example, right, where the body's using about 25% of this. Increased insulin, right, in the high states of carbohydrates intake, right, it's also going to convert this glucose into glycogen. So it's going to basically store this. Anyone know what are predominant tissues that has glycogen stores in our body?
Liver and muscle cells.
Liver, muscle cells, and also kidney, right? But which can, and kidney cell, but which can actively mobilize, meaning in the cases of low sugar, which can actually dump that glycogen into the blood as sugar.
Liver
Liver?
tissue.
Liver and kidney, right? To a small degree, kidney can also, right? Muscle cannot, right? They don't have that, the final step that basically makes glucose 6-phosphate into glucose. It doesn't have that enzyme to break it down. That's why muscle cannot do it. Glucose 6-phosphatase is missing there, right? So it cannot take glucose 6-phosphate into glucose. So your liver and your kidney is the predominant, players there. Glycogen stores are probably exhausted within the 24-hour time frame. So anything after that, you're not basically getting glycogen stores broken up. You are switching into gluconeogenesis, formation of glucose from non-carbohydrate sources. Right. Insulin also increases amino acid absorption, right, and protein synthesis, and it also increases, fat synthesis and adipose tissue. So basically, insulin does all these effects. It makes sense, right? I just ate a carbohydrate-rich meal. Maybe there's other, sources of calories there, right? Fats, proteins, and so insulin will basically help with storage. On the other hand, right? Let's say we have low sugar, right? So blood glucose level is decreasing. And so this could be maybe you haven't eaten in a while, right? Or you're going into starvation. That could be one of the reasons. Could be also, right? You have low glycogen stores. We have a lot of, alcoholic patients especially, right, who consume alcohol, but they do not consume calories from food. So they have calories from their alcohol intake, but nothing else. So they may have low glycogen stores. And so how does the body react to that? So as I said, right, the body is going to secrete these counter-regulatory hormones. Glucagon is one of them. So when is glucagon released? When the glucose is gone. Which cells release it? Alpha cells of the islets of the Langerhans in the pancreas. And you see here, right, where does this going to work? It works on the liver. It's going to work on the skeletal muscle, hopefully, but skeletal muscle is not going to really provide you with the active sugar you seek, right, an adipose cell. Right, so it's going to increase breakdown of glycogen to glucose in liver and skeletal muscle. So this, in liver, this can go into your circulation, right? But the one in the muscle is only going to be used by the muscles themselves. So to fuel them, whatever needs it needs. So muscle. So it's not going to be released into the circulation. So the skeletal muscle glycogen is not going to be of use to you, right, in your bloodstream. They're only going to be utilized by skeletal muscle. It's going to increase breakdown of fat to fatty acids, right? Fatty acids can be converted to acetyl-CoA, right, which is, we can utilize as a substrate again. And here we have increased synthesis and release of glucose in the liver, right? So in the liver is, we're going to basically release it into the stores. And hopefully this will drive our blood glucose level up, right, to restore the homeostasis. So these two hormones, they work and they're basically work in opposition, right? One is to basically uptake the glucose and store it. The other one is to release the glucose from the glycogen stores. Hopefully that's clear. Do you guys have any questions about insulin or glucagon, where it's made, what are the functions?
Okay, Nico.
Yeah.
The body now is going into ketosis, correct?
When?
When you're breaking down the fat.
Yeah,
And
if you prolong this state, the starving state, the body can then start to make ketone bodies, right? It's basically using this, right? Acetone is one of them. And that's why acetone is one of the ketone bodies. That's why patients with DKA who has started to make that, you could see that fury breath, right? That's basically formation of ketone bodies. And that's usually something it's usually something we do not want the body to go into. By the way,
So the body,
what is the main reason we give insulin for patients who have DKA, diabetic ketoacidosis?
To stop ketosis.
Yeah, to basically stop, right, acidosis, the formation of acidosis. It's not to basically drive sugar into the cells. That's the byproduct of it, right? But we want to stop this ketoacidosis, right? Ketoacidosis, formation of these ketones, which are acidic, right? That's the major reason we give insulin.
Yeah. Okay. Thank you.
Any other questions? All right. So here, the other stuff of this, right? We're going to go into the adrenal cortex. So here we have a picture of the adrenal cortex. These are located, right? Adrenal glands sit on top of the kidneys. We have two kidneys, and these adrenal glands sit on top of the kidneys. They have a couple of different zones, right? We talked about, if you want to remember a term, right? In the kidneys, you have something known as GFR. This is called glomerular filtration rate. But if you remember this 1, 2, and 3, let me take a different color so you guys can see. 1, 2, and 3. This stands for zona glomerulosa, zona fascicularta, and zona reticularis. And these are the zones, right? So we see zona glomerulosa, fascicularta, reticularis. And then when we get to adrenal medulla, this is basically from the surface area as you penetrate inside the adrenal cortex, right? And here we see them, right? So here you have the zones. Do you need to remember the zones? Not necessarily, right? Just something to keep in mind that there's 3 zones. And more importantly, right, what you want to remember is this. One of the hormones that are secreted by the adrenal gland, right, is aldosterone. If you want to know where it's secreted from, it's from zona glomerulosa. And aldosterone helps us with salt and water retention, right? The medulla portion of it, right, is what secretes epinephrine and norepinephrine. So these are your hormones in response to, I should say, shock status or fight or flight response, right? Epinephrine, norepinephrine made in adrenal medulla. But the cortex, which is on the surface, right? Medulla is towards the inside, as we see here. And on the surface, right, we see these 3 zones, the cortex. Right? So glomerulosa makes aldosterone, fascicularta makes cortisol, and reticularis makes DHEA, which, it's androgens. Further, you can convert to basically testosterone or estrogen down the line. So these are the zones, right? So they give you basically what it makes. For your purposes, as I said, what you want to remember, the adrenal gland makes aldosterone, right? And the medulla makes epinephrine or epinephrine. When do we need aldosterone? In the setting of low blood pressure, let's say shock. Aldosterone helps us to retain salt and water. How does it do? It works on the kidneys, right, to reabsorb salt or sodium, and then water follows along with it. This is just showing you, right, epinephrine or epinephrine we just talked about, right? So here we see the adrenal medulla. It's stimulated by sympathetic control. And these receptors, right, the ones you need to know for these exams, or for this exams, I should say, is, I'll write them out here. So beta 1, beta 2, and alpha 1. And just to go through it, beta 1 is going to be found predominantly on the heart, one heart. So beta 1 is going to increase your chronotropy, right? Increase heart rate. Beta 2, you have two lungs. So beta 2 found on the lungs. Effect of epi-norepi is going to be causing bronchodilation. And then alpha 1 is found on your arterioles, and that's responsible for smooth muscle contraction or this increase of systemic vascular resistance. So this will drive your blood pressure up. When we give our medications, right, oppressors specifically, right, norepi, high dose dopamine, vasopressin, right, drip, epi pushes, we want to exert this alpha 1 response to increase systemic vascular resistance. Here we see, right, the adrenal medulla, as I said, it's towards the inside, right, and it secretes epi and norepi, and the response, right, is going to be similar once it binds to the target receptor. So this is what we want to know, right? So just to show you, right? So alpha 1, and we said these two. Why beta 1 shows you here, right? This renin release, because I said, right, in the kidneys you also have beta 1 receptors. When the sympathetic stimulation in the setting of shock, right, works on beta 1 in the kidneys, it's also going to increase renin release. Renin is also going to be increased when you have low flow states, right? So low blood sugar, low blood pressure. So that renin is going to be released by the juxtaglomerular apparatus. We're going to get to that shortly, right? So it's very important for that. So these are the receptors you want to make sure you know. The other thing that we talked about, right, was this hemoglobin A1C. And when we're talked about hemoglobin, so you have different forms of hemoglobin. Hemoglobin A here, the predominant, right? Hemoglobin's job is to carry oxygen to the tissues, but there's something known as hemoglobin A1C. We test that, I should say not we, but the doctors test that in the hospital setting for diabetic patients, right? Can anyone tell me what's so special about this hemoglobin A1C?
It checks your blood sugars levels over a period of time.
Okay, and how is that important? Why is that important, I should say?
Because you could see the trending of the blood sugars. Like if you just check a blood sugar on the spot, it could be 120, but over a couple months, it could always be like 500 all the time.
Yeah, excellent. So excellent. What Aaron is saying is correct. So imagine you have a diabetic who is not compliant with their insulin or whatever medications they were prescribed, right? And so I go out, I buy some Coca-Cola, I buy some fries, I buy some, ice cream, I gulp it all down. I do this every day. I don't really adhere to my drug regimen, right? But today is my appointment to see my primary care, and I know they're going to check my sugar. So I have my own glucometer. I check, it's 300. No, not good. I, pull up my insulin, right? Give me a shot, and then, as time goes by, let's say it goes back to, 100, right? 100 milligrams per deciliter. So I go to the doctor's office. I'm like, yeah, doc, I'm compliant. I take these drugs. I'm good. The doctor checks my sugar. Let's say at that point it's at 100, or maybe got, even less than that, 90, right? You probably fooled the doctor, right? But guess what? They're going to check your hemoglobin A1C. That's glycosylated hemoglobin. And we know your red blood cells in your body have about, 3 months lifespan, right? So if you constantly have high sugar, right, this will be elevated, right? So we see like 9%, 10% of this, so that they know that, you're not really compliant with your drug regimen, right? So that's why they trend this hemoglobin A1C. It's basically one of your hemoglobin forms, but this is the predominant one for carrying, right, oxygen. So the next thing we're going to talk about, right, is the posterior pituitary, right, gland in your hypothalamus. and the hormones it secretes, right? So the posterior lobe of your pituitary gland, the ones that we are paying attention to is the ADH, or antidiuretic hormone, and oxytocin, right? ADH, another name for it was vasopressin. Sometimes you will see it written as arginine, vasopressin, right? It's just the how it's made and traveled in our body as normal hormone, right? Antidiuretic hormone, or AVP, is the same thing. We give vasopressin as a medication. It's in your protocols. It's one of the vasopressor agent. Before the changes in AHA, we used to give it in place of epi as as our vasoconstrictor agent. It basically works on different receptors. You have V1, V2 receptors for vasopressin to cause vasoconstriction and to reabsorb water from the kidneys. So it just does that on different sites as opposed to epinephrine, right, which is beta or alpha mediated response. So this is the posterior pituitary gland that we are focusing here. And I have some questions there. The anterior pituitary, I don't think I have that many questions there. The growth hormone that we were talking about earlier is made by the anterior pituitary gland. In terms of your thyroid gland, couple of things, right? We talked about the role of this in your calcium control, right? So we know a normal level of calcium is 9 to 11. So if you want to remember it, if you call 911, right, your normal calcium is 9 to 11. Less than 9 is hypocalcemia. Above 11 is hypercalcemia. You have different hormones that regulate this. On the thyroid gland itself, this secretes calcitonin. And your parathyroid glands, they secrete parathyroid hormone, right? So this one is usually secreted when you have high calcium levels. So it's above 11. And this is secreted when you have low, let's say less than 9 milligrams per deciliter. So calcitonin when your calcium is high, and then parathyroid hormone when your calcium is low. So here they show you the two different conditions. So let's go with high, right? So let's say your blood calcium level is high, and the body is going to respond to that, right? The C cells in the thyroid glands, they're going to secrete calcitonin. Calcitonin is released when your calcium level is high, right? And here they give you the normal range between 8.5 and 11. So let's say it exceeds 11. So this is when it's going to release. It's going to work basically on the kidneys, digestive tract, and also on the bones. And the whole goal of this, right? You want to excrete calcium, excess calcium by the kidneys, right? And what you want to do is you want to reduce the absorption, right, of calcium from the digestive tract. So it prevents the absorption of calcium. So if you get rid of it in the kidneys and you absorb less of it in the digestive tract, and also calcitonin works on the bone, right? It tells them basically not to resorb or break up the osteoblasts. And the result of this is you want to restore that balance. On the other hand, if you have low calcium levels, right, below this number, what's going to happen, the parathyroid, right, is going to secrete the parathyroid hormone, PTH. And it's, again, is going to work on the kidneys, right, digestive tract and bones, but it's going to do something slightly different. It's going to work on the bones to resorb, to basically break bone tissue so that bone is made of calcium. Calcium goes in the blood, and then kidneys are going to reabsorb calcium instead of dumping it into the urine, right? So, and here we see calcium absorption in the kidneys. We also see this calcium released from the bone because the bone is being resorbed, right, by the parathyroid hormone. And we also see these, this is called calcitriol. It's made in the kidneys, and it does absorption, right, of calcium in the digestive tract, right, in your intestines, and also it decreases release of calcium by the kidneys, right, into the urine. And all the goal of this is basically to restore calcium. What do we use calcium in our body for example? What do we need calcium for?
To make the bone stronger.
Okay. We could
It's
that's
used-
one of the reasons to make the bone stronger, but besides that,
Isn't it used in like the refractory period of the myocardial?
yeah, so what you're saying, it's using the plateau phase, right? And remember, let me see if I can, well, you guys remember I was drawing you, right, this diagram of your,
The action potential.
yeah, and this, right, we said, if you remember, this was phase 4, this was phase 0, this is phase 1, 2, and then 3. And you remember I was drawing you this diagram, right, where at this point we have potassium that's open, potassium channels, I should say. Potassium is leaving, and we have calcium that's coming in, right? And as you have positive leaving and positive coming in, it creates this plateau phase. Make sense, right? So calcium is utilized there. There's some other tissue, right, that uses calcium. Anyone remember?
Muscle cells.
Isn't
Muscle, right? And what's the role of calcium there?
Contractibility.
contraction?
And how?
It needs to move it acts on troponin to remove the tropomyosin and allow the myosin to bind.
Excellent,
to,
excellent. Right, Milan is 100%. So calcium comes in, binds to troponin. Once the troponin is bound, this is all on the thin filament. It's going to signal the tropomyosin to basically move out of the way, exposing actin active site, where myosin head can dock. Right, I explained all this in the other videos, but basically, role of calcium in muscle contraction is this: calcium comes in, binds on troponin. This signals the tropomyosin to move out of the way, exposing the actin thin filament. Myosin, which is the thick filament, then binds, right, to the actin and causes this power stroke to occur. And then we have ATP coming in, again, reverting it back to the resting status, right, back to the cocked position, so it's ready to roll, right? So this is some of the examples where we employ calcium. Another thing that you may remember, right, in the setting, right, of SVT, right, or rapid AFib, you may call medical control, and if the blood pressure is good or elevated, you may ask for diltiazem, which is a calcium channel blocker. But some doctors, when you call them up, they'll say, hey, I want you to pre-treat your patient before you give this drug with calcium chloride, right? Give them IV calcium. So the goal is to basically mediate that smooth muscle dilation that calcium channel blockers will also provide, right? So if you see, right, if I give you calcium channel blocker, calcium channel is not coming in, you may not have that contraction, right? And they also cause vasodilation on the smooth muscle and in your arteries. So they will pre-treat them with calcium, and then you give your diltiazem, so hopefully it exerts its cardiovascular effect without the hypotension associated with it, right? So something to keep in mind.